All right, so when we're looking at the brain vibration work, I kind of oversimplify the way this works, and it doesn't work this way, but we're going to keep it really simple. Imagine that you have poles, just like a computer, and these poles are what generate your electric charge, and then you have several poles all over the place, and that's kind of your grey matter within the brain. And then these poles have wiring that all hooks in between them, and the way the wiring runs is what allows you to run your programs. So what we want to do is stimulate these poles first, and we want to do it in a way that is as least stimulating as possible. So the easiest way to do that is via vibration. Once we've got that right, then we want the patient to stimulate them directly, which gives you another level of input. And the third thing we want to do then is to look at dual tasking, which means using as many of these poles at the same time as we can in the same pathway. So for instance, we could use right cerebellar and left frontal lobe. We could use both frontal lobes together by tapping both. We could use frontal lobes and vagus, a whole heap of different things. We'll work through them as we go. So to look at the vibrational side of things, whenever we want to check cortical function really is all about extensor tone. So we're going to need to use an extensor to perform this. So what we're going to do is find an extensor, make sure they're all working, so we can push back this way, push back this way. The other one you can use is supinator, which works quite well. So keep the hand there, just don't let me turn it down. So there's one, we could use this as well. We could use all the way up, push back. We could use lower trap, this side. So any of the extensors, the easiest one to use though is the mid trap. Now what we're going to do is we're going to vibrate the cortex on the ipsilateral side. Okay, so we're going to take, in this case, the right extensors, look at thumb position. So extension and external rotation is a cortical action. So when we get into this position, what we should have is the hand like that. If you have patients that struggle to get back and are in this kind of position, this is most likely already to be a lack of cortical tone. So you can already see that from that effect. So what we're going to do is turn it all the way back that way. Test first. And now what we're going to do is go through and vibrate the entire cortex on that side. So we start cerebellum, parietal lobe, onto the temporal lobe, even lower over the ear, then frontal. Okay, then we're going to do the same thing on the opposite side. Test. And if we look on this side, we can see we've got less external rotation there. If we ask him to fully rotate, he does it. So we see we're getting less output from that side of the cortex. So we vibrate here. On that left side now, we've got poor function. All good, all good, all good, all good. Now what we want to do is we want to work out if the problem here is the primary problem or not. If you've only got one issue, it's always going to be the primary problem. When you've got several issues, it's easy to work out. So let's say we had left cerebellum, right frontal lobe. We want to work out which one it is. We're just going to find one of those areas. So let's take the left cerebellum, bring the arm back. What we're going to do is going to get him to hold the vibration device, the massager, over that area and just keep it switched on. And with the magnet on the south pole, which is what we're going to use for TL, we're going to push back. We're going to go to those other areas. So is that cerebellum? No benefit. Frontal? No change. Over this cerebellum? Changes. So what we know now is that this cerebellar issue is the primary. This is the one we need to work with, okay? Just like when you're using standard AK tests and you're trying to find which is the primary problem, same thing with this as well. So now what we're going to do is we're going to come around the other side. So when we come around this side, now what we're really looking for is flexor tone. So remember our standard gait patterns. So your PMRF inhibits extensors at the top, inhibits flexors at the bottom. So this is what we're going to use, this gait patterning. So if we've got an extensor weakness here, what we'll have is a flexor weakness here as well, or hyporeactivity. So what we're going to do is we're going to get him to vibrate this area again. And this time we're going to check the flexors on this side. Push towards me. Push to me. Okay, now we've got an inhibition pattern or a hyporeactivity problem. So what we want to find out now is which meridian is causing that problem. So we're going to run all the B&E points. Generally, it's on the contralateral side to the vibration. Not always, but generally. So we're going to run through it again. So we're going to vibrate, and we're going to go right through all our B&Es. So there's nothing there with the face, so we're going to go onto the trunk. And what we find is the right circulation sex meridian is showing up. So now what we're going to do is we're going to look for where along the circulation sex meridian we're having that problem. So we're going to vibrate it again. And this time we're just going to TL along the circulation sex meridian. So still weak, still hyperreactive. Okay, this area here now, that's negating it. That's negating it. That's negating it. Problem again. So we've got a stretch of about 3 or 4 inches there that we've got the problem with. So what you should be able to do is you should be able to palpate the change in that meridian. So if I feel right now, there's not really much there, it just feels like normal tissue. Vibrate the skull. And what you'll find is it starts feeling ropey and it will get tender. Tender, yep, and we can feel that there. Take it away. Does that change that tenderness?
It does.
Yep. So when you vibrate it, it's tender, and you can feel it. When you take the vibration away, that tenderness disappears and the ropiness under the meridian goes as well. Now the only problem with that is that the vibration device only goes a very small way into the brain. It doesn't go a long way into the brain, so we need to go deeper into the brain. So the way we do that is by using the south pole of the magnet. So we'll put the south pole over the magnet over that area for treatment as well. The problem with it is if we put the south pole over that area, it goes so deep into the brain, we highlight so much of the brain, this is going to be so exquisitely tender that we're not actually going to be able to treat it. So we start gently and we build up. So the way we do this is vibration device on, and we just rub that out. And it will be tender, and you'll feel the tension in that tissue dissipate. So there's a bit of a nasty one in there. Okay, so we're starting to settle, and you should find that the pain is settling down as well.
Yeah, it is,
yep.
Yep. Feel the tendon.
So we're still a little bit there, but it's not too bad now. That's freed up.
Still a bit there.
Okay. So now we take that away, and now we go to the south pole. South pole on. So we're going deeper into the brain, a further level of input, which means this will wind this up again. So let me know if it's tender now. Yep. Take it away. Compare. Yep, put it back on. Okay, so that's how we know we're on our spot, and we're going to do the same thing again. We're going deeper, so generally it's a lot more sensitive, and you'll feel a lot more ropey in that area as well. Okay, so that's settling down nicely now. Okay, so start with vibration. Find the area of the brain. If you have more than one area, find the primary area. That's the area that you treat. Then go back to that area, vibrate it, come to the opposite flexor, use the flexor then to find the B&E point that we need, whether it be on the trunk or the body. Then find the area of the meridian that needs to be treated, then treat it with vibration, and then treat it with the magnet. Okay, and that's step 1 with it. So now if we go back and check that extensor again, we're on the left side. Okay, to start with, he's already turning a lot more backwards with his hand. We've got a lot more external rotation there. We vibrate it now. And no hyperreactivity, no inhibition now when we do that. Okay, so we can see how that's changed. So what we're really looking for with that is what we call down regulation of the brain. So now we want to look for up regulation. So the difference between this has no effect on flexor tone. You'll still find flexors change in the same way. This is why we use the extensors. However, what we will notice though is when we do this is that the extensors will become hyperreactive when we vibrate a brain that's overstimulated. So we bring the arm out again. This time, push back. Solid this time, we're going to test K27 at the same time. That's for hyperreactivity. And we're going to vibrate again. Cerebellum, no problem. Parietal, no problem. Temporal, no problem. Right frontal. If you take your hand off K27, it doesn't test, put your hand on K27. So what we're seeing there is a hyperreactivity. So now I'm going to go to the other side. K27 again, cerebellum okay, parietal okay, temple bone okay, frontal okay. So what we're left with is just the right frontal. So this time, We're going to therapy localize it again, but the TL really, what we're doing is looking for up or down regulation, which is what we're using the south and the north pole of the magnet for. So this time what we're going to do is we're going to use the north pole. Okay, it's up regulated, the north pole will help bring it down. We're looking for what normalizes it. So we do the same thing again. Vibrate. Okay, 27, we're going to run out of hands here. So this time what we're going to do is going to put the vibration device under the magnet and check. And that negates it. So what we're seeing here is that the primary issue with this frontal is the frontal itself. Okay, so this is what we're going to treat. So we're going to come back around here, same as we did last time. So we use this extensor. This time we're going to use this flexor. So in the exact opposite pattern than what we were before. The reason we don't need to, if we vibrate, we can see we turn off. The reason we don't need to worry about hyper and hypo is flexors don't really give a crap about much. There's a general understanding that says if you want to know something intelligent, don't ask a dumb flexor. Okay, so this is what we're looking at here. So this is the reason why we use extensors first, because if you can work out up or down regulation, you can't work that out using flexors. So what we're going to do is the exact same thing. So we're going to hold that there and vibrate that for us. And then run through our B and E's again. No, 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 no. Onto the body. No, 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 no. Other side. Okay, so right K27 is negating it. Okay, so we're looking at right kidney meridian. So we're going to go down to the leg now. I'm going to drop this video down a little bit. So we're going to go down to the leg, keep vibrating up there. Push to knee. We're going to go up the kidney meridian. Okay, so there's one, another. Alright, so we've got a small segment just below the knee. So we're going to do the same thing we did last time. We're going to feel for the ropiness in the meridian. And we're going to go, is it tender through here? Yep. Take the vibration device away. Does that change that tenderness? Yep. Put it back on again. We're going to treat that, get rid of the ropiness. So unlike ligament interlink, so you get the same kind of feeling as lig interlink, but with the lig interlink, generally speaking, you'll feel the tenderness go out within a few seconds. This stuff can take a fair while. Sometimes it can take 30, 40 seconds to get that out. That's already starting to settle down now, which is good. So we take that away. Treatment still under the South Pole. Okay, we still treat under the South Pole, not the North Pole. North Pole is only for diagnostics. So South Pole, over the frontal, and we're going again. Tender again. Yep, treat that. Lovely. Okay, so we're going to take that away. We'll go back and recheck it again now. This hand back. Yeah, grab that because you've got an edge on the hand on K27. Turn it back, push back. Lovely. So that's now clear. So we can go through and check the rest of the brain. Sometimes when you clear something out, other things will become apparent. So you sometimes need to recheck a little bit over and over. Just turn this around a bit. Beautiful. Okay, so once we've done that, the next thing we want to do is single task the brain. If we've had people who've had traumatic episodes, so severe injuries, broken bones, something that's generally changed the quality of their life, sometimes what you then need to do is do the same thing, but do it with recalling the event. So what we could do is go, okay, so say you broke your leg when you were 12 and that's when this problem started. Then what we could do is, okay, think about that broken leg, and then whilst we're thinking about the broken leg, then vibrate the whole brain as well, because sometimes that will pull things out that you don't normally see, which is what we call adverse memory retention. All right, so the next thing we want to do is go into single tasking. So if we look here at Michael, what we've seen is left cerebellum, right frontal, which is a single pathway, the cerebellofrontal pathway. So we're going to just check them to begin with. So easy way to check your cerebellum is your DDK, so alternating hand movements. So what we're going to do is take an extensor, push back, all right, and all we're going to get him to do is do his alternating hand movements on that left side and recheck, and we have a problem. Okay, so if he keeps doing that, up, down, up, down, up, down, left hand, okay, and all we're going to do is use the south pole of the magnet to identify where in the brain is that coming from. So left side all good. Okay, so right side we're getting that temple area. Okay, so keep doing that for a sec with your left hand. And stop. So now if we turn the hand in, take a flexor and challenge that with vibration. Now it turns off. Okay, we were all clear before. So we go through and you treat that exactly the same way that we did with our previous session. So what we're basically going to do, vibrate, find the meridian that's involved, clear out that meridian, and then come back and recheck the DDK and it should be good. Once you've done that, so it's single tasking. So you want to do that in all areas where you have deficit. So if you have someone with a vagal problem, this is what you're going to do. You're going to check all those vagal signs. So you're going to go ocular pressure and use that to test with. You're going to go humming, gargling if need be, anything you can think of in those lines. If you're talking about frontal lobes, we're going to go finger tapping, we're going to go lateral saccades with the eyes, anything that you can use to trigger it, okay? Once we get through that, now we need to go to dual tasking. So dual tasking is the two areas, okay? So we're looking at, say, his right frontal lobe, then we want to dual task the frontal lobe. So we think of two actions that we can do to utilize that frontal lobe. So if we take the extensor on this side, push back, we can go left hand tap, 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 which is stimulating that right frontal lobe, which is all good. And then at the same time, we can get him to do saccades to the left, which is using the right frontal lobe. So we put two marks on the wall. So we go, hey, look at this and look at this dot. And all we're doing is going straight, left, straight, left. So you want to make sure they're fixating to a point, okay? So it's not kind of just gradually getting there and back, gradually getting there. It's like, look here, look here, look here, look here, look here, look here. So that saccade will stimulate the opposite frontal. So if we're tapping this finger, and we're going left, straight, left, straight, left, straight, and you can see that turns him off. What we're saying is that when he uses two poles within the frontal lobe, the net result is his system switches off, it can't cope. So therefore, inherently, his system isn't going to want to use those two aspects of frontal lobe function at the same time. All right, so this is how we correct this now. So go again, straight, left, straight, left. So we've got inhibition, grab the south pole of the magnet and run it around the brain. So occipital, cerebellum, parietal, down to the temple, frontal. Okay, so lo and behold, the right frontal stabilizer. It doesn't always work that way. It can be a total different structure. So we could come back as a left cerebellum because we're not getting input. Could come back to the other frontal because it's over dominant, a whole lot of different things. So in this case, it comes back to that side. So what we're going to want to do then is, using photobiometrics, so we can use laser, we can use LED panels, whatever it is, we want him to do that exercise whilst we're using the photobiometrics on that frontal lobe, okay? So in this situation, we go tap, 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 left, straight, and all we're literally doing is lasering that area, okay? Once you've done that, you'll find that that's no longer an issue. Okay, that test no longer shows up. If we have someone who has a really severe neurological problem, the easiest way to do it is to upregulate the whole mechanism. So hyperbaric chamber, put oxygen into the brain first. Then photobiometrics. The whole purpose of photobiometrics is to upregulate mitochondrial action. So now you've got more oxygen in the area, more mitochondria in the area, so therefore you get rid of neuronal fatigue, which means the nerve is more likely to be able to grow and stimulate. Then you want to do your exercise. So what you'd have is a patient going into the chamber, directly from the chamber into the room at the photobiometrics device, and then doing their exercise in front of the photobiometrics. So in this case with Michael, he'd be going straight, left, straight, left, straight, left whilst tapping, and having the light coming at his right frontal lobe to stimulate growth. Okay, so there are 3 steps when looking at the vibrational material. We'll put down a few steps and a few things you need to be careful of underneath, but that's the general process to make sure that you can upregulate all this It's the easiest way to start the rehab process with people, simply because getting compliance on neural exercise is very, very poor. In order to get people to do the neural exercise, they need to do things they're not good at. That's not enjoyable, and if they don't enjoy it, they'll inherently want to not do it. And that doesn't mean you're getting conscious conflict, but they'll forget to do the exercises all the time. It's very, very hard to do unless you're pulling them into the office and getting them to do that here in front of you all the time. So hopefully if we do it this way, the result will be you'll get some improvement in neural function, which means if you need to do then neural rehab, the process is then much easier for the patient to proceed with.